good afternoon to everybody. Or I don't see anybody else who may be in the evening or the morning, but whichever time zone you are, great to see you. And so we are back on our fourth and final webinar on Gaucher disease, neurological phenotype. And I've been given the part to just do an update and then share with you some cases. Now, there's not many of you, so I'm going to ask you to all, you're going to have to put things in the chat when I have my cases. Otherwise, I won't advance the slides, and it's going to become a very long meeting. So even if you put in don't know, that would be absolutely fine. So while I'm muttering along, let me just see if I can quickly bring up my screen. You can see the beautiful Yorkshire there. And hopefully, there we go. And you should be able to see my slides now. So we're talking about tools and what's helpful for people going forward. So I thought something that would be really interesting and helpful potentially is I looked at the previous three episodes we've had on this topic. Let me take this away because everybody will see that. And really, I thought, let me use one of the AI tools just to see if I feed it the webinars, what would it actually tell us? And does it give us a good summary? So the first two slides are AI generated, so please keep that in mind, but that's intentional. It's not because. So what I would want you to say is that firstly, they said that when diagnosing Gaucher type 3, the important clinical red flags are really the eye movements, difficult jumping eyes between 2 points, look for the compensatory jerks, and some head thrusting, which I thought was really interesting. It then talks about the massive hepatosplenomegaly with the big livers and spleen, and to remember there are many chameleons or things that looks like Gaucher, which are more common, but which could be missed, and it then limits them to malaria, TB, leukemia. So I thought that was quite a good entry point to think about what are the critical things. And then it talks about the African diagnostic roadmap. And I'm delighted that we've got Helena Conradie on tonight as well. She'll talk a little bit more about that. But in essence, what it picked up is really good, that if you suspect a patient, you need to do the dried blood spot testing, which is a DBS. There is a facility to do some gene confirmation. And then it's a multi-system disease. And basically, the sooner you make the diagnosis, the better the outcomes. And I thought that was actually quite a good summary of what happened in the first three episodes, but it also gives me an intro into, I do a lot of AI work at the moment intentionally to improve healthcare service. But it's a really important thing to know that you've got to monitor it, and you really have to know, and I'm not going to talk about how you do this, but you train the models. And I must say, I was relatively impressed by what the trained model did, just to see, because as we're starting to get further and further along, I think it's important for us to start thinking, how can we use tools to make things better, but also to know the limitations of these. And this is no different to when we started off with genetic testing many years ago. So know your tools and know their limitations. So let's see if it will allow me to go. So the next thing, it says, why is Gaucher type 3 missed? And it made this lovely table for me, which I thought was really good. So it said, you have to look at both the liver and the spleen, the hematological profile, the neurological or eye signs, and the diagnostic hallmarks. So if you then work from the top down, let me just grab this one too. So if you work from the top down, you would say, so for malaria, you get an acute splenomegaly, usually. You've got a hemolytic anemia. Your neurological signs are usually negative, and you get a positive parasite smear. When you go then and you look at tuberculosis or TB, you see it's a gradual wasting and slowly, more slow process. Hematology is often normal in the beginning, normal eye movements, and then you tend to do a gene expert or an X-ray really to get most of the tests done. When you look at sickle cell anemia, splenomegaly is early. I mean, the hematology, you see the hemoglobin S percentages. There's usually no eye movements, and the vaso-occlusive pain signs may be a link. Now, Gaucher bone crises can be just as painful, but they've got usually a different pattern of distribution. They usually tend to go for the spine and they go for the hips. So not entirely the same, but it can be. And those with much more experience in sickle cell can correct us, and feel free to put it into the chat if you see what is the patterns, because we know the phenotypes are different in Africa. But then basically for Gaucher 3 talks about a massive progressive hepatosplenomegaly, just disproportionate pancytopenia, thrombocytopenia, horizontal gaze palsy, and negative infectious markers. So I think that was just really, and the takeaway is that Gaucher disease is no longer a diagnosis of exclusion. It's highly specific, identifiable clinical target, as long as you actually think about it. So let me just look somebody, okay. There's nothing important in the text yet. And I'm going to start off with, and I want you to start thinking. So let's see. Here is my first case, and please go into the chat because I'm going to look there. This case and my two cases are both African cases. This is a 26-year-old male who presented with epistaxis after sporting activities. Now, if you turn up in the A&E department with a nose that's bleeding after a rugby match, you must probably be part of the team. However, why this guy kept on coming back is the main thing is that the epistaxis wouldn't stop. So although he would put pressure and everything on it, he just couldn't stop it. And he ended up having to go to the emergency department and get his nose packed with compression bandages or with catheters, which are pulled through, for those who are aware of how we do that, just to stop the nose bleeding. And then it would have to stay in overnight. And if he took it out too quickly, it would restart. So it was quite an unusual way and quite a significant amount of bleeding. He had no significant family history, and the full blood count which was performed showed a low platelet count, but otherwise nothing else. So now I'm going to wait in the chat. Somebody's going to put in the chat for me. What are you starting to think? What are the kind of things in Africa that you would think causes this kind of a history? Anything. Can be an infection as well, although less likely, but of course, I'm going to give a while then, get anybody to see if anybody's brave enough to put anything in the chat. Put it in there for us if you're brave enough. If nobody's brave enough, I will move on to the next one. But I really want people to start thinking through. And maybe there's not enough information, and I give that validly. So maybe we need a little bit more information. So let me give you another piece of information, which may or may not be useful. So here's the next piece of information. So a bone marrow aspirate was done, and the hematologists can tell us what they think about this. I'm not one of those. I have very little clue. I can tell you what the report said, but this is many of the things are not the true patient's things for privacy concern. I've taken similar examples, which is in the public domain. Anybody want to be brave enough to say anything that you see there? Now, normally, I would think we're talking about Gaucher, so we're going to be looking for Gaucher cells. Now, I couldn't see any Gaucher cells. I know some people say it looks like you've got some tissue paper, and this one there, I thought, oh, that may be suspect, but it doesn't really look like a Gaucher cell to me at all. So I don't know if anybody wants to be brave and say what they think it is. If you don't know, there's no comments in my chat already. We've got a quiet group tonight. I'm going to go on to the next one, but have a think about it. So, and you can also disagree. So please, if you think something is not right, but this is through patient case. So what happened? Let me move that out of your way. So the report said this looks like a empty bone marrow is the wording that was used, and most likely ITP. The patient was treated with steroids, but he had very little response in the platelet count. And that was his story. He had the bleeding nose and nothing else. Then about 18 months later, he came back with an acute abdomen. Now again, rugby player, either you've ruptured a spleen or something, being in a brawl or something, or appendicitis, and all the common things which are there. And for most of the acute abdomens, we start with ultrasound relatively quickly, even in the African context. They had a quick look. And the interesting thing is they found that he had some gallstones and a mildly enlarged spleen. And they analyzed the gallstones, which contained cholesterol, but the serum cholesterol levels were low. Anybody want to make a diagnosis here? Anybody there thinking they've got an idea of what we're dealing with here? So you've got a patient with epistaxis, low platelets, doesn't respond to steroids, although the bone marrow is quite suggestive, by which the hematologist thought of ITP. And then the patient presented with gallstones, and these are cholesterol stones, although the cholesterol is normal. Come on, anybody. You have to try and take a guess. I mean, look at the title, what we're dealing with today. Any ideas of what this could be? If nobody's brave enough, I will move on. I don't see anybody chatting now. So we've got a really quiet group today. Good. Let me put you out of your misery. So this is not the patient's stones, but this is another one which is confirmed. So actually, because the patient had this unusual ITP picture, which doesn't respond to steroids, and also had these gallstones, the hematologist was quite smart and said he's read about hypocholesterolemia and cholesterol stones in Gaucher disease. So actually requested the testing, and the patient was confirmed. So this is not the patient's images. This is from another case which has been published. And although this is a rare presentation, it is one of the features of Gaucher disease. And actually this one is a Gaucher type 1. So this is not a Gaucher type 3 or a neurological presentation Gaucher, but it's a patient who presented with a very, very unusual but mild phenotype of Gaucher disease. And for those who are much more interested in it, I'm trying to remember from memory, he was an N370S L44P in the old nomenclature. So a mutation which is seen with the common Ashkenazi Jewish type, which is usually type 1, but then another mutation which is more frequently seen with a neurological phenotype. So this is just one of the local cases. So I'm going to have a quick look and just make sure there's nothing in the chat. We've got the Quiet 19 online today. Let me go on to the next case for you. Now, I've got a 58-year-old female patient presented with a hoarse voice. She had a history of weight loss over 9 months. BMI was 15 when she got to the clinic. On the full blood count, she had a macrocytic anemia. She had mildly elevated white cell count with monocytosis. Platelet counts were normal. She's had multiple admissions for pneumonia, needing antibiotics. She had a CT of her larynx and upper airways, which only showed a left-sided vocal cord paralysis. She had a cardiac evaluation, which showed mild mitral valve regurgitation. She had an abdominal ultrasound showing an enlarged liver and spleen, but not massively, and she had a normal brain MRI. Anybody brave enough now to start putting anything in here? Let's see if anybody's brave to put anything in the chat. Any ideas what we're dealing with here? So you've got a 58-year-old who's losing weight. She's got a macrocytic anemia, multiple admissions for pneumonia, and look like she's got a left-sided vocal cord paralysis. Any ideas? Still, it seems that we've got the quiet group here. Okay. More information. She had a video fluoroscopy which showed aspiration, which is silent aspiration, meaning she didn't cough, it just goes in, and it's most probably the cause of all of her recurrent pneumonias. She started on some thickened fluids and was given advice on what foods to eat and how to limit aspiration. She was given a high-calorie diet. Her vitamin B12 level was low, so she started supplementation of vitamin B12, but she was progressively getting worse with neurological decline. Any offers in the chat? Still no one willing to put anyone in there? Doesn't look like we're going to get anybody in. And then this happened. Patient sent this image and said, I coughed last night, and this is what came up. Any ideas? Come on, where's my colleagues? Any ideas what that looks like? Somebody's asking, there any other signs of mediastinal syndrome? No. And there was quite a good investigation to follow the nerve out to see if the vocal cord paralysis has got anything abnormal. Also looked at abnormal glands, potentially. There was a few glands, but nothing major that was pressing on the recurrent nerve, as you would usually see, because as you would know, the left side has got the longest path to go and is the most frequently one which is the cause for it. So you've got this really odd kind of thing which you're not sure, is this kind of sputum, or is this maybe unusual, something they inhaled or anything. So I'm going to put you out of your misery because I think everybody's. And can I say, none of you should feel bad about what you've done. The first case was seen by, I recall, about 5 different specialists before the diagnosis was made. And it was the hematologist actually that first picked up on the potential link between the cholesterol stones. And the second patient, somebody asked chest x-ray. Yes, chest x-ray was entirely normal. But I think the patient is on the right track there, who's asking the questions. So let me put you out of your misery. And I'll take that off again. And that was sputum that showed acid-fast bacilli. There was a positive gene expert test. Chest x-ray was actually negative. And it was confirmed this is a patient with unusual presentation of neurological TB, but after TB medication made a full recovery after 4 months. And the reason why I brought this patient, interestingly, is it's one of the cases I found where Gaucher was actually in the differential diagnosis early on, and TB never made it in there. So this was just one of the interesting cases, and I thought it'll be a good one to share with everybody. So hopefully people find it interesting. And like I've said before, please feel free to add in the chat and things like this. This is interactive to see how good we can get. So I'm going to stop my share there, and I'm going to give you all back to take over. And I think we're going to hand over to Derralynn, I suspect, which is going to be driving next, but please correct me if I've got that wrong.
Right. Thank you, Chris. Just going to share the screen. So I'm going to share, but Amy's going to present the first couple of cases and then I will take over. So these are some case studies that we hope are a little bit challenging, and there'll be some polls. So
fabulous. So we're going to start off by talking about a child, and that's why I'm going to talk about these ones as a paediatrician. And we're going to think about a child coming to you with fits or seizures and a big tummy. And so what we want you to be thinking about is when you should be thinking about type 3 or neuronopathic Gaucher disease. Particularly when these patients come and you're not expecting, because we don't go into clinics all the time unless you're Derralynn and I and Chris and think about Gaucher disease necessarily. So let's have a look at this first case. So you've got a 7-year-old patient, a girl living in a rural area, and she's referred by a district hospital. and she comes with generalized seizures from the age of 3. She's got an enlarged abdomen, progressive gait difficulty. She has frequent infections and her weight isn't good, so she's growth faltering. And you take a family history and find out that there have been deaths in childhood. So I can see messages popping up in the background there. On examination, she's got massive splenomegaly. She's got hepatomegaly. She's got a squint or strabismus. There's clear developmental delay. There appears to be some learning difficulties, and she will not sit still in the clinic room. She's running around, and she's got anemia. She's pale, but there's no lymphadenopathy. And you managed to do some investigations, and these are as demonstrated on the right-hand side of your screen. So a full blood count, or a complete blood count, as some of you may call it. So the HB is 7.1, platelets are 68, white cells are 3.1. You've done a malaria screen and it's negative. You've got a slight elevation of liver enzymes. The ultrasound of her abdomen confirms what you found when you've examined, so massive splenomegaly and hepatomegaly. There's some generalized slow wave activity on the EEG, and your HIV and TB screens are negative, and your LDH is elevated 4 times the upper limit of normal. So that's your case, and here is your question. So you've got this child, 7-year-old, 4 years history of seizures, big spleen, developmental delay, some learning difficulties. What additional clinical sign would you examine for, or which additional investigation would you do if you were thinking about Gaucher disease as a diagnosis? So your options are an MRI brain, so an investigation, saccadic eye movement examination, look for ataxia, or would you do neurocognitive testing? What test or investigation would you do? So you can either put it in the chat, or you can click on the poll and we can see your answers on the poll as well. Okay, so we've got a few people thinking do a brain scan, and the majority thinking examine for horizontal saccadic eye movement. So let's go to our next slide, which will show us the answer. So the answer to this one is B. So what we're thinking about here is recognition that your clinical examination is going to give you that clue. So the thing that takes you away, that's going to be more definitive and specific about neuronopathic Gaucher disease, are these saccadic eye movements. You could do a brain scan, but it's not going to give you a specific answer. You may see some abnormalities, you may not see some abnormalities, but it's not going to help you with your diagnosis. Again, examining for ataxia, you may find it, but it doesn't tell you that this is most likely to be neuronopathic Gaucher disease. And again, the same with your cognitive testing. It confirms some of your findings, but it doesn't give you a clue to diagnosis. And here we're thinking, okay, what's going to help us direct our investigations further? And what we really need to remember is that this horizontal saccadic eye movement defect is one of the most specific associations that we see in neuronopathic Gaucher disease. So it's something that you want to be able to recognize, and you want to know how to examine for when you see a child with this kind of complexity in your clinic. Let's go to our next question. So you suspect that this might be a lysosomal storage disorder, and your laboratory has no enzyme assay available. What is the most accessible next diagnostic step for you? And so these are your options. So we've got bone marrow aspirate, MRI brain, whole exome sequencing, or just start them on some enzyme replacement therapy. What would you do? And so this is the question 2 on your poll. Shall we reveal the poll results? So we've got some people saying A, and this is our answer. So bone marrow aspirate. So this is where you're going to be able to see, or hopefully be able to see, the Gaucher cells. And this is something that you will be able to do. It's not what we would recommend if you had availability of enzyme testing, if you had availability of genetic sequencing. It's not what we would use diagnostically in that scenario. But where you don't have an enzyme assay available, then this is going to be your diagnostic test. Again, the imaging, the sequencing, and enzyme replacement therapy are all things that you may use, but only when you've made your diagnosis. And this is what's going to help you with that diagnosis. So as we've talked about already, we would see this crumpled tissue paper appearance of the Gaucher cells. And this is a low cost, although it's invasive, it is an acceptable test that you could use, and a very practical first step when you don't have an enzyme assay available to you. Okay. So you've made a diagnosis and the family asks you about treatment, and it's not available. So enzyme replacement therapy isn't available in your country. So what's your immediate management priority? So we've got A, start high dose anticonvulsant polytherapy immediately to suppress all seizure activity. B, refer urgently to a specialist centre abroad to get access to ERT. C, provide supportive care. So optimize your seizure control, prevent infection, address nutritional deficiencies, ensure the correct diagnosis and pursue specialist linkage. Or D, advise the family that without ERT, nothing can be done and the prognosis is universally poor. So nobody went with A. The answer we were looking for was C. So I think what we have to remember here is that although enzyme replacement therapy is really good for visceral disease, so for your systemic manifestations, for your hematological manifestations, and your enlarged liver and your enlarged spleen, it's not going to correct your neurological disease. And so for a child like this with established disease who has a significant neurological disease burden, we have to think holistically, and we have to think realistically about what we can offer this patient. And what we really want you to be doing is to think about the whole patient. So don't think about individual aspects of their disease. We want you to think about the whole patient, because that's what is going to provide them the best quality of life, and what is going to ensure their overall health. So think about that in that kind of setting. ERT is a part of the piece of care, but it's not the whole care. We don't want to be removing hope and support from our patients. So giving them really bad news that without this thing, this ERT, we can do nothing. That's not true. We can do a lot for patients, aside from enzyme replacement therapy. We didn't want you to answer with A because seizures, again, are not the whole story for our patients. And the reality of being able to suppress all seizure activity is not realistic. And so we have to manage the benefits and risks of anti-seizure medicines. Referring patients abroad for enzyme replacement therapy, again, we're not thinking about the whole patient. And so what we want to do is think about the things that we can intervene with. So we can manage infection, we can address nutrition, we can make sure that we're treating the right condition, and then we can think about access to other specialist services as and when we need them. I think we've got another question on this case. So if you are thinking about this patient, and we're thinking about the whole patient, which of these problems do you think this child might face in the future? And I've got a feeling I didn't actually complete this the way that I'd intended to. So we'll see what you all come up with. So we've got which other problems? So spinal deformity, depression and anxiety, bone disease, or hearing loss. What do we think? So the answer here was that all of these are potential problems. for patients with neuronopathic Gaucher disease. And these are just some of the potential future problems. And I think we have to be really mindful of that. So they will have challenges with visceral disease, systemic disease, which will affect their bones. We see spinal deformity, so both kyphosis and scoliosis. We have a huge burden of depression and anxiety in our NGD patients, and many of our children also have hearing loss. So these are some of the things in addition to the other neurological things that you're already aware of. So the seizures, the developmental challenges, the growth challenges, and the hepatosplenomegaly, the thrombocytopenia, all of these things as well that we need to be thinking about also. Do we have another slide? Fabulous. So to summarize, when we're thinking about GD3 in a child, we need to confirm our diagnosis, and we use the methods that we have available to us. So if you can do an enzyme assay, that's great. If you can't, think about a bone marrow biopsy or a bone marrow aspirate. We want to think about optimizing seizure control, but we have to evaluate that the burden and the side effects of anti-seizure medicines with the impact on the patient as well. We want to think about the things that we can intervene with. So if you have a profoundly anemic child and you've got iron deficiency, these are things that we can treat. We want to monitor for infections and immunize our patients as much as we possibly can within our means. Nutritional support is something I'm very passionate about, and you've heard me talk about it already. So think about how we can optimize nutrition in our patients, because you will improve the whole health of the child if we achieve this. Think about how we can access therapies, so managed access programs, compassionate use programs, and then think about the whole neurological and developmental assessment of a child. Remember that ERT doesn't cross the blood-brain barrier, and so therefore does not have a significant impact on brain disease associated with Gaucher disease. However, managing visceral disease well will improve your brain health overall. Learn and think about your gaze palsy, so your saccadic eye movement defect, and understand how to evaluate this so that you can recognize it when you see a child with a constellation of different symptoms and signs. And remember that there may be affected siblings and there may be an impact for future genetic counselling. So think about pathways to genetic counselling for the whole family. We're probably not diagnosing Gaucher disease as much as we should, so we're probably missing these diagnoses. So think about a child that's got unexplained splenomegaly and neurological signs, and think about Gaucher as one of your differentials. Think about how you can access your compassionate use programs, and then think about how you share your learning and build that regional diagnostic capacity with your local labs. Okay, then I think we've got another case of a child, but with this time we're going to think a little bit younger, and we're going to think about babies, and when we might think about a GD2 or an acute neuronopathic diagnosis. All right, so this is our next case. So this time you've got a tiny baby, 5-month-old boy from a peri-urban area, born at term, normal delivery, formula feeding and challenges with feeding. And the referral is for a child that's got developmental delays, beginning to evolve to see that developmental delay. We often don't see, it's not very clear in those first few months of life, but we've had feeding difficulties from the 2nd or 3rd month. And they've got this unusual posturing shape with retroflexion of the neck. There was a rash in the newborn period, a kind of petechial rash, an unusual rash. And there's a history of sort of choking aspiration episodes as well. And when you examine this little boy, they're incredibly small. So this is a very low body weight baby, clearly growth faltering, the kind of baby that you start to unwrap the clothes and there's this tiny little emaciated baby underneath. They feel a bit stiff peripherally. This neck is flexed back, and they've got a hard splenomegaly. So you can see the tummy's not grossly distended. It's just a bit big given how emaciated this baby is, and the organs feel firm. And when they do open their eyes, you can see this squint, so this strabismus as well. This baby has also got a low hemoglobin, a low platelet count, and there's been a bone marrow aspirate already, which demonstrates the Gaucher cells. The chest X-ray shows evidence of aspiration, so consistent with the history of possible aspiration episodes. And you've got severely deficient glucocerebrosidase enzyme as well. The Kaito is markedly elevated. And you're waiting on the GBA gene results. And because of where you are and what you've heard about this, you're suspecting this might be an L444P homozygous baby. So our question, you've got this 5-month-old baby, growth faltering, feeding difficulties, opisthotonus and hepatosplenomegaly, and you've got bone marrow showing Gaucher cells. And your dry blood spot shows this reduced enzyme activity. So what is your diagnosis? Excellent. So we're all saying B, that this is GD2. Fabulous. And let's go to the next slide. So you've got all of the features there that give you your diagnosis: low enzyme activity, a clinical picture, and a bone marrow aspirate. So the next question is, the family's heard that ERT exists and is asking you to start treatment. And ERT is available on compassionate use. What's the most accurate statement from the ones below about ERT in type 2 Gaucher disease? So A, ERT reliably halts neurological progression in type 2 if started before 6 months of age. B, ERT significantly improves visceral disease, but does not cross the blood-brain barrier and does not alter neurological decline, so the prognosis remains poor. C, ERT is contraindicated in infants under 12 months due to severe infusion reactions. D, ERT combined with miglustat has been shown in randomized controlled trials to improve survival beyond 2 years in type 2 Gaucher disease. What do you think on this question? Yeah, so B is the answer that we're looking for. So again, as we said in the previous case, we know that ERT improves visceral disease, but it doesn't cross the blood-brain barrier. We've gone to a black screen again, and I'm not sure why. So when we're thinking about GD2, we have to remember that. And also we have to think about the practicalities of delivering enzyme replacement therapy to infants with GD2. So we've already said that this is a very small, emaciated little baby. And so we have to think about what are we trying to achieve. And in fact, often with our GD2 babies, their visceral disease is often not as profound as our GD3 infants. And so the benefits of ERT are maybe less in a GD2 patient than they are in a GD3 patient. And certainly my practice in the UK is that we generally do not offer ERT to GD2 patients, particularly if they were presenting at this kind of age. We have to be really transparent and honest with our families because sometimes we want to do something and sometimes that's actually not in the best interests of children. And so as much as our intention is good and we feel a need to do things, sometimes the kinder thing is to do less and to do supportive things. So let's go to the next question. Understandably, these parents are devastated with what you've just told them. You've told them the prognosis. Which approach to family support and clinical management is most appropriate in this setting? So A, send them straight to a pediatric intensive care unit for ventilatory support to maximize life expectancy. B, advise the family that nothing more can be done and discharge them home without any follow-up. C, initiate palliative care, so prioritize comfort, manage aspiration risk, support feeding, provide family counselling, and discuss end-of-life planning really sensitively. Or D, recommend a repeat bone marrow biopsy monthly to track the disease progression and guide your therapy decisions. So our answer we were looking for here is C, and we want to initiate palliative care. And when we're saying palliative care, I think we have to be clear about what we mean by that. So often palliative care is thought of as being synonymous with end-of-life care, and it can be that. But really, palliative care is about prioritizing of comfort and holistic care for a patient. And so that's thinking about all of the things that could happen with this patient and how do we support them rather than intervene to have a specific outcome necessarily. So if we were to recommend that all patients were transferred to intensive care, we could be successful in prolonging life, whether that was prolonged comfortable life, I think is arguable. And therefore, sometimes a prolonged life is not in a patient's best interest, particularly that of a child. Discharging a patient home without any follow-up seems somewhat unkind. And this is devastating for families. And typically, if you have a baby with GD2 who presents around 5 months of age, many of those infants will not survive a further 2 or 3 months of life. In our experience in the UK, any of the babies that I've seen at that age with this kind of presentation sadly die within a few months. So this is rapid by the time they reach you. And so therefore that kind of answers the question for D as well, that repeat painful, uncomfortable and not really useful bone marrow aspirates it is not helpful. So we want to be supportive in the things that we do, and that includes emotional and spiritual support for the family. And we have had scenarios where we've had children in intensive care for a variety of reasons, usually because they don't have a diagnosis, and that's usually not a pleasant experience for the patient or the family. We go to the next one. We might have put another question. And so what aspects of this baby's condition might you want to counsel the families about? So what things are risks for this baby that the family need to know? So would you say risk of bone disease and fractures? Would you tell them about risk of hematological malignancy? Would you tell them about progressive swallowing and feeding difficulty, seizures, laryngospasm and apnea? Would you talk to them about ataxia and eye movement problems? So C is the answer that we were looking for here. While all of these other things can be associated with other forms of Gaucher disease, in GD2, this is the natural progression of the most severe forms of GD2. The swallowing and feeding gets worse, so there's aspiration risks there. We want to get rid of any oral feeding as soon as we possibly can because it becomes unsafe. Seizures can become problematic and very distressing, but the most distressing feature of this condition are these awful laryngospasm episodes. So the upper airway goes into spasm, it causes apneas, and they are incredibly distressing for families. And preparing families for this is challenging. But having an awareness even in your own mind that this is something that can happen and sharing that with professionals around this family is important so that you can plan how we're going to manage those if they happen. So thinking about GD2, we want to confirm diagnosis, ideally with the enzyme assay and genotyping if possible, and hopefully in the future we'll be able to share with you a bit clearer kind of genotype to phenotype expectation, particularly in GD2. We need to be really clear when we're giving diagnosis and giving prognosis to families. This has to be done compassionately. We have to engage as much support for this family as we possibly can, and then focus on comfort. And so that involves tone management, anti-seizure medications when you need it, positioning, pain management, assessing feeding, and providing interventions to support feeding, because nobody likes to not feed a child. But we need to make that as safe as we can so that we limit the complications of it. Again, always optimize nutrition where you can, but avoid the aggressive interventions. So ventilation, lots of lines, cannulation, painful things that don't really alter the disease course. Think about counselling for future pregnancies for the family, and use whatever social services, bereavement counselling, palliative care, community care that you can access to support this family. This is a horrible condition, particularly the early onset forms, and we want to be aware of that. And you need to understand that this is where this disease is going when you see a baby with this condition. ERT is not going to change that course, and it's not practical often to deliver it. And again, thinking about that future pregnancies, and thinking about how we can access prenatal diagnosis for future pregnancies. This is really hard. This is about expectations, understanding, and hope for people. And we have to be respectful of that. We have to be not just culturally sensitive, but sensitive to people's faith and beliefs. And that's a challenge. But I think going in open-minded, and with that understanding of where this disease is going is really important. And we need to have networks for you so that you can access the support in how to deliver this information, and when and how to think about family planning for future pregnancies. Now I think we're going to move to an adult.
So this is our final case in this section. I'll go through it fairly briefly in view of time. So this is about a young adult who is known to have neuronopathic Gaucher disease, having monitoring for disease progression, and the ERT supply was interrupted. So a 23-year-old male from an urban environment. He'd been diagnosed at the age of 9 and had some interruption of enzyme replacement 14 months ago. He was developing increasing bone pain. He'd had a couple of bone crises, fatigue and breathlessness. His spleen and liver had both enlarged. He still had supranuclear gaze palsy, some myopathy, kyphosis. And his blood workup showed that he was anemic and thrombocytopenic. He had classic Erlenmeyer-Flass deformity, some other changes on plain X-ray of the hips, and some elevation of biomarkers. So the first question, so this patient's ERT supply had been interrupted for 14 months. The spleen had grown to 15 centimetres and the haemoglobin dropped. So what does this clinical picture confirm? So in this particular situation, the answer is B, because we know that enzyme had been interrupted. And so he was having worsening visceral disease. In fact, if we'd not known that the enzyme had been interrupted, then A would have been a very reasonable answer, given that we need to think about other diagnoses to explain the splenomegaly or or hemoglobin and so on. So I think that's a good idea always to think about other pathology, particularly things that we know are more common in Gaucher, such as hematological malignancy. We know the previous event wasn't a placebo, and of course there may be dual pathology, but more than likely that bone crises are referable to Gaucher rather than sickle. So the next question, you have no MRI available to assess the bone pain. plain x-rays show Erlenmeyer-Flass deformity and subchondral sclerosis. So he's got severe hip pain. What is the most appropriate next step for bone management if you don't have advanced imaging available? So you can vote on this. So prescribe high-dose long-term non-steroidals, perform some surgery to try to alleviate the pain, optimize the analgesia and other medications, or just simply reassure the patient that this is all benign and doesn't require any further action. So optimizing analgesia in whatever is appropriate and available for that patient is really important with what may well be a bone crisis. And then thinking about longer term treatments with optimizing vitamin D and calcium, enzyme replacement therapy. And it may be that a referral to orthopedics is required for a joint replacement at some time. So it should be considered, but not necessarily as the only activity for this patient. So I think what this case really highlights is that people who have had enzyme replacement for some years with more severe Gaucher, be it neuronopathic Gaucher or severe type 1, will have recrudescence of some of the features if they come off enzyme. For people who are milder and more stable, then they might be able to have treatment holidays for quite some while without seeing too much in the way of clinical effects. But people with more severe disease, over some time, you might start to see increased spleen, biomarkers, reduction in hemoglobin. And the thing which is a particularly risk and which is disabling and will have longer term impact on quality of life and potential mobility is if there is a bone crisis. So important really to think about all of those monitoring and applications should there be an interruption of enzyme replacement therapy. And important really we try to protect that supply. So we've been through 3 cases with quite a lot of questions around recognizing the hallmarks in terms of eye movement abnormalities, things about diagnosing practically if we've not got advanced tests or more complex tests for enzyme activity or genetics available, then thinking about how we can use a bone marrow to make that diagnosis. We talked about enzyme replacement therapy and its role in addressing visceral disease and not neurological disease, and that in the context of both acute and chronic neurological disease, so type 2 also, but monitoring with the tools that we've got and trying not to interrupt treatment if that's at all possible through our various activities. So I will stop sharing there and hand over to whoever is next.
Perfect. So we're going to change a little bit of track now. So I'm coming in from a lab perspective, and I know that for enzyme replacement therapy, you will mainly need to have testing, enzymatic testing or genetic confirmation. So we want to offer a little bit of light. There is testing available on the continent. We've been working together with Chris Hendriksz and together with International Gaucher Alliance for a number of years now to set up a network across Africa, and we've been systematically expanding the footprint in Africa to more and more countries. And I'm briefly going to present to you about that in the next few slides. So just a little bit of background on the lab where I come from. So we are university based. We are one of 2 laboratories in South Africa that perform tests for inborn errors of metabolism together with normal research functions that's associated with academic setting. And we also have funding from government for metabolomics expertise. So we are also known as the National Metabolomics Platform in South Africa. So this is just in a nutshell who we are. I've included the link to our website there so that you can see the different diagnostic tests that we offer, as well as research opportunities that we have available, and a little bit more about the platform. So you're welcome to scan the QR code if you want to find out more, and our contact details are also on the website. Also, just a very brief background because I'm aware of the time and I want to go more into the practical workflow in the next few slides. So the LSD impact network coverage is shown there on the left-hand side, the first map. So you will see that we've got already a large footprint across Africa. And then the second map in the middle shows the number of referrals that we have received as part of this initiative to date. And then the pie graph on top is the one that I'm most excited about. So what we typically see in South Africa from our lysosomal storage disorder testing referrals, before we do any interventions and awareness trainings on the disease and how when to suspect the diseases, we had about a 2 to 6% diagnostic hit rate for referrals that ends up in a confirmed diagnosis for the 6 lysosomal storage disorders that makes up the lysosomal storage, the 6-plex LSD test. What we have seen through the Africa Network and the Capacity Building in Africa initiative is with intense training and regular training and specific events to increase the awareness on what to look for, that this has actually helped a lot to get more accurate referrals for the test. And we are at this stage very close to the 50% mark of all referrals ending up in a confirmed positive diagnosis. So that is really good to see that the effort is paying off, and more events like this is critical to ensure that we keep this going forward and that we increase the awareness on the diseases. So next I'm going to go into the specific step-by-step workflow for what we call the 6-plex LSD test. So the 6-plex LSD test is basically a single test that we have that is set up for specific lysosomal storage disorders, namely Gaucher disease, Pompe, Fabry, MPS, ASMD or Niemann-Pick, and Krabbe disease. So whenever you have a strong clinical suspicion for any one of these 6 diseases, you request a 6-plex LSD test. It's one test that's performed, even though you indicate your strong clinical suspicion for one of the 6, all 6 are tested simultaneously. It is an enzymatic test on LC-MS/MS. We work in collaboration with Sanofi South Africa, that has assisted us in setting up the test and is currently sponsoring testing in South Africa. And International Gaucher Alliance has assisted us in obtaining funding and direct relief as well to provide testing for the Africa Network as well. So what we do, step 1, you will contact us at the lab. We will send you a kit. In the network that I've shown on the previous slide, there's already a number of kits available in the country, but if there is none, we will definitely make sure to send a sample, a kit to you as soon as possible. The kit contains all of the required documentation in terms of patient consent, clinical information, the DBS kit itself, as well as a step-by-step instruction that I'm going to go through now on the correct DBS collection, handling procedure, shipment, etc. After you have collected the test and it's dried for the appropriate amount of time, the sample will get shipped to South Africa via the Lancet labs where they are available. There's 1 or 2 countries in the network that there's no footprint yet for Lancet, but we have successfully worked with neighboring countries as well to get samples sent to the neighboring country where Lancet has a footprint, and then getting the samples to South Africa. We are currently in process as well to streamline the logistics with Lancet through formal service level agreements that's per country level. So this is a really big step for us as well to formalize and make this more sustainable going forward. The Lancet lab will then use a specific mnemonic that they've set up in the labs to lock the sample. The sample gets shipped to the Richmond lab in South Africa, and the Richmond lab in South Africa sends the sample to us the same way that the normal LSD referrals in South Africa takes place as well. Then when the sample reaches the lab, we have a 10-day turnaround time for upon receipt of the samples for the enzymatic test. And when a test is abnormal, we refer them as well to Archimed for confirmatory testing and genetic confirmation. We are also working on options to perform the genetic confirmation in South Africa, which will decrease the 12-week turnaround for the genetic confirmation that we currently have significantly. So that is in a nutshell the different steps. But if we have an abnormal enzymatic test, you will automatically receive a preliminary report from us so that you can already start looking at options and treatment options and advise the patients further while we still refer for the genetic testing to Archimed. This is just two pictures showing you on the left-hand side how the kit looks. So this is an A4 envelope with all of the documentation inside. And then on the right-hand side is the specific DBS card. It's a Watman 903 card. But because we refer at this stage to Archimed, there's a specific information that they want together with the samples. So just a few things that I want to make you attentive on is to please check the expiry date of the card to see if it's still valid. If the card is past expiry, please contact us to know if we will still be able to use that card or if we should maybe send you a new card. Please complete the patient information, and then for your own records, on the right-hand side of the card, there's a red number. That's a tracking number for future communications. Please keep that at hand. It just enables us to facilitate communication between us and Archimed if we want to inquire about results. And then very important, at the bottom of the card, you will see the different tests. So there are more tests there than the 6-plex that we offer enzymatic testing for, but please select only the most appropriate. As I mentioned, we will in any case test for all 6 conditions. It is important that you select only one option there. For instance, if you suspect Fabry disease, female, it automatically gets sent to Archimed as well for additional tests that we are unable to perform in our lab, as well as for MPS. We are able to test for specific subtypes of MPS on enzymatic level in our lab, but an expanded MPS is offered automatically by Archimed as well. So if you suspect MPS disorder, please select that so that we know to send the sample for that purposes. It just delays the turnaround time quite significantly, and it makes sure that you are able to get access to these additional tests that's offered part of the contract that we have with them. Now I want to go in a step-by-step DBS collection. It is really important. I know it sounds simple to do a blood spot, but what we have seen and feedback that we've had from onboarding training events, in-person training events from the clinicians, is that it actually helps to have a step-by-step approach. We've seen that by doing this, we were able to minimize the artifactual results that we receive due to poor sample collections or inappropriate sample collections as well, from a 40% down to a 10%. Very important, please make sure that all of the information on the cards are completed in full. The second step that you need to know, please wipe the area where you want to do either the finger prick or the heel prick to disinfect. Please do not use any iodine disinfectants, as this can cause interference with the test. So just a normal alcohol swab is sufficient. We recommend that patients younger than 6 months receive a heel prick, and older than 6 finger prick. If the timelines is not that strict, but basically if a child can already walk, then rather do a finger prick. If the child is not yet mobile or walking and crawling, then you can do a heel prick on the child. Please, no venous blood or EDTA or any type of anticoagulants or heparin or SST blood tubes. Rather do the prick with the lancet because the chemicals in the tubes and the blood collection tubes interfere with the results. Very important as well that after you've pricked the site, the image there shows you to please do the prick to the side of the finger or to the side of the heel. And then important to wipe the first blood drop. So this helps to eliminate the coagulants and make sure that we get a nice proper on the cards and it doesn't interfere with any of the testing. So very practical approach. People also want to know how big a drop do you need on the blood spot. So what our lab technician has always told us that do not milk the finger. Keep it pointed downwards, and then when it feels like the drop is about to fall to the floor, that's the point where you make the drop on the blood spot. It will be a large enough volume that it can saturate all the way through the cord, and that is exactly what we want. What we do not want is any overlaying of samples or any addition. So please do not drop more than one drop on a specific place. It really interferes with the samples as well. So only one drop per circle. Please do not spot on both sides of the paper to make sure it goes through. Remember, the entire Whatman 903 is a filter paper. It's treated the same way. So if you were unable to spot correctly within the circle, if you are able to do another spot that's not in one of the designated circles, that is also perfectly fine because the card is the same throughout. There's no special pre-treatment in this designated circle areas. Then very important as well, the DBS samples are a bit sensitive for extreme heat exposures and for extreme humidity. So please just dry the cards at normal room temperature for about 4 hours until the spot is completely dry before you close it off and putting it in an envelope. There's no special equipment needed for the purpose to leave the cards for 4 hours. A normal box that you can cut slits in the box and place the cards in there to allow them to dry for 4 hours before you close them in a Ziploc bag with a desiccant that's included in the kit. And then after the collection is done, please take it to your nearest Serba Lancet branch. Or if there's no Serba Lancet, we will assist you in next steps to get the samples to us. Typical errors that we usually see that cause artifactual results, if there's any type of contamination with water, powder, or anything that was on the surface, so the card was left lying on a bench top or a desktop or anything where dust and things can interfere, so that can cause artifactual results. We sometimes see a serum ring on the samples, and that is typically when a site has been milked to get a nice enough blood, a big enough blood spot. What we have seen from practical experience at recruitment clinics as well is that MPS patients tend to have a slower blood flow. So warming the site of the prick will usually help to stimulate the blood flow without milking it. So if you can just ask the patient to warm their hands or underneath the armpit or something, just so that it's warm enough, and then you can do the finger prick, it really helps with that. We often get a super saturation where more than one drop has been spotted over each other, and that causes artifactual results. We also see very often clearly that the syringe has been used to spot the samples, and you do not get that fully saturated spot that you're able to punch in the lab for the analysis. And often enough as well, missing information that cannot be relayed back to a specific patient, and we cannot process the samples further. So just in a nutshell again, so if you need any assistance with a patient, to refer them to us. you are welcome to use the email address and the phone number that's provided on the screen, or on the contact page of our website. From there, we will be able to assist you to give through these details, because I know it's not going to be feasible now for you to remember all of these names, all of these addresses as well. So we will send this information through to you in a separate email. It's just important that when you suspect a patient, please contact us, and we will put you in contact with the closest Lancet branch, or the clinician that we have onboarded already that can assist you with kits. And the process from there will be collecting the sample, taking it to a Lancet lab. They will log it on their system, send it to us, and from there on, we will be able to give you reports back. So that is me in a nutshell, and I'm happy to take any questions that you might have. And please feel free if you need any assistance with logistics regarding sample collections. Please feel free to contact us at any stage. Thank you very much.